Your rheumatoid arthritis was under control. You had found the right medication. You had the routine. Life was manageable. And then when menopause hit, suddenly everything fell apart. More flares, more pain, more stiffness every single morning. You went back to your rheumatologist, they ran some labs, they saw the numbers climbing, and they said, let's increase your medication. But here it is, the question that nobody asked you. Did anyone check your hormones? I'm Dr. Girnita, a double board certified rheumatologist with 20 years of clinical experience. And what I am going to tell you is something that most of my colleagues will not. We are trained to look at joints, antibodies, and inflammatory pathways. We are never or almost never trained to look at hormones. And that is a massive gap, because what happens to estrogen during menopause directly, measurably affects what happens to you with rheumatoid arthritis. And why the conversation you are not having with your rheumatologist might actually be the most important of your entire care. Today, I am going to show you the science behind this connection, what the 2025 research actually says, and why the conversation that you are not having with your rheumatologist might be the most important one of your entire care. Here is a number that bothered me for my entire career. 80% of autoimmune diseases happens in women. I knew this number since medical school, and for years I accepted it without truly questioning it, until I started looking at why and when those diseases appear. Autoimmune diseases in women don't occur randomly across a lifetime. They cluster at very specific hormonal movements. During the childbearing age, when the estrogen surges, after pregnancy, when the estrogen crashes, and during perimenopause, when estrogen becomes unstable, and after menopause, when estrogen essentially disappears. This is not a coincidence. This is biology telling us something. And once you see it, you cannot unsee it. Estrogen is not just a reproductive hormone. It is an immune regulator. When estrogen is balanced, it acts as a natural brake on inflammation, which will keep your immune system from becoming overactive, protecting joints, protecting the bones, the blood vessels, and other tissue. When estrogen drops, that brake is released. The immune system becomes more reactive, more inflamed, more likely to turn against yourself. And in women who are already carrying an autoimmune diagnosis like rheumatoid arthritis, that hormone destabilization at menopause can be that event that will tip the balance dramatically in the wrong direction. I spent years watching this happen in my clinic without fully understanding it. Women whose rheumatoid arthritis had been stable for many years, they suddenly had the worst flare-ups ever around menopause. Women being diagnosed with rheumatoid arthritis for the very first time in their early 50s after a lifetime of normal joints. The research is now confirming what I was seeing, and it is time to talk about it openly. And they ask a clear question: does menopause status affect how rheumatoid arthritis progresses? And the answer was without ambiguity. Postmenopausal women with rheumatoid arthritis had worse physical function, they had higher disease activity, and they had faster functional decline compared to premenopausal women with the exact diagnosis and on similar medications. But what stopped me was this: women in this study who had used hormone replacement therapy had less functional decline, no more flare-ups, not more disease activity. They actually had less. Estrogen was not making the disease worse. Its absence was the cause. That changes everything about how we should think about women with rheumatoid arthritis in menopause time. Another study, a major 2025 analysis, combined data from 11 large international studies, and they find out that women who go through menopause before the age of 45, they were up 2.5 times higher the risk to develop rheumatoid arthritis compared to women who reach menopause at a normal age. And here it is what makes this particularly alarming. Many of these women had completely normal blood tests, normal rheumatoid factor, negative CCP, normal CRP, but yet they had clear joint swelling, they had morning stiffness, and they had pain. And this is seronegative rheumatoid arthritis, which is real, it's active, it's progressive, but it's invisible to the standard markers that we rely on in clinic. Women going through early menopause are actually at significant risk, higher risk of developing this form of rheumatoid arthritis, seronegative rheumatoid arthritis, that is particularly likely to be dismissed or actually missed completely because all the markers were negative. And if you're not a rheumatologist to recognize that, you can miss this completely. Another brand new study, published again in 2025, followed Canadian women for over 10 years. And they found out that those who went through menopause at the age of 50 or later, and those that use hormone replacement therapy for 8 or more years, they had 80% lower risk to develop rheumatoid arthritis. And they compared them with women who had early menopause and they never used HRT. Do you listen to this? 80% reduction in risk from hormone timing and from estrogen exposure alone. This single study can actually rewrite how we should think about menopause management for every woman with rheumatoid arthritis or a family history of rheumatoid arthritis. Now, here is a study about anti-CCP antibodies, and this one genuinely surprised me. Researchers studied women carrying a specific gene variant that doubles the rheumatoid arthritis risk. And we know these kind of females will have rheumatoid arthritis almost inevitable. The woman who used hormone replacement therapy had a more than 50% reduction in anti-CCP antibody production. And these anti-CCP antibodies don't just show up just as a blood test. They are associated with aggressive and destructive forms of rheumatoid arthritis. And they also appear many years before the symptoms ever begin. And HRT cut their production in half in genetically predisposed women. In some women, particularly those with early menopause and a family history of rheumatoid arthritis, hormones may be one of the most powerful preventive tools that we have. And almost no one that I know is talking about it. I know what you're thinking right now because my patients will say to me every single week, but I hear that HRT causes cancer. My doctor told me never to take it. Isn't it dangerous? Now, that fear comes from one study, the Women's Health Initiative study, which was published in 2002. The headlines were everywhere. Hormones cause cancer. HRT is dangerous. And millions of women stopped their therapy overnight. But here it is what those headlines missed. And we as doctors missed it too. The average woman in that study was 63 years old, more than 10 years past menopause. It was designed to study disease prevention in older women, not symptom treatment in women in their early 50s. And the risk increase that they reported, they actually used a relative risk, which sounds dramatic, but in absolute numbers, the actual increase in breast cancer was 8 additional cases per 10,000 women per year, which is less than 0.1%. Meanwhile, the estrogen-only arm of that same study showed something almost nobody had reported. It was showing that estrogen alone actually reduced breast cancer risk and reduced the breast cancer mortality up to 40%. And in 2025, the FDA removed the broad black box warning from menopausal hormone replacement therapy. And they acknowledged that the original interpretation of that study, an overly generalized, and millions of women suffered for 20 years through bone loss, cardiovascular decline, joint pain, sexual dysfunction, because of a headline that missed the nuance. So what do current guidelines actually say? The American College of Rheumatology strongly recommends hormone therapy for postmenopausal women with rheumatic diseases, including rheumatoid arthritis, who had significantly menopause symptoms that are under the age of 60 and within 10 years of menopause, and women that have no major contraindications. And the ACR guidelines is also explicit. HRT does not make established rheumatoid arthritis worse. It may actually provide additional benefits to the disease activity and bone protection. Now let's stop for a second. There are many women who need a more individualized, personalized discussion. And those are the ladies with a history of breast cancer, with active cardiovascular disease, with prior blood clots, with lupus, or with antiphospholipid syndrome, but for most women with rheumatoid arthritis, HRT is not the dangerous thing that they have been told to fear. The absence of estrogen may be actually far more dangerous for their joints and their bones than a dose that is carefully chosen, appropriately dosed hormone replacement therapy. I want to be honest about something that I'm not proud of. For years, I watched women in my clinic go through perimenopause and menopause while their rheumatoid arthritis got harder to control. I adjusted medications, I switched biologics, and sometimes it helped, but sometimes, even when I did everything right from my rheumatology point of view, it was not enough. And when I referred this woman to a gynecologist or a menopause specialist, they would come back to me and tell me that doctor would not treat me. They said, I have an autoimmune disease and they are afraid to touch my hormones. The menopause specialist was afraid of autoimmune diseases. I was not trained in hormones, and my patients were stuck in the middle. They were sicker than they needed to be because two specialists could not work together. And the truth, most rheumatologists will not say it loud. When estrogen drops during menopause, inflammation increases, disease activity score increases, and we record that as a rheumatoid arthritis flare-up. And we typically increase the immunosuppression without even asking what is actually the root of the problem. Is it hormonal? Adding more medication to a patient whose disease is flaring because of hormonal destabilization does not fix the hormonal destabilization. It manages the downstream consequences while leaving the upstream completely untouched. This is why I decided to partner with Dr. Mirela Titianu. She's a certified menopause specialist. She's a board-certified internal medicine physician, obesity medicine, and lifestyle medicine certified. And we have built the Women's Hormone and Autoimmune Balance program here at Rheumatologist OnCall. It is one program with two specialists who actually speak to each other. Zero gap between rheumatology care and your hormonal health, because that is what you have always deserved and what the current system was never designed to give you. Here is what I want you to take from this video. Menopause and rheumatoid arthritis are not separate problems. They share a biological estrogen. And when estrogen drops, rheumatoid arthritis often accelerates. The research is clear. The guideline supports it. And the FDA finally caught up. HRT, when it's used correctly in the right patient at the right time, it is recommended by the American College of Rheumatology for most postmenopausal women with rheumatoid arthritis. The fear around it was based on a 2002 study that was misinterpreted for 20 years. But that chapter is closed, and if your rheumatoid arthritis got harder to control since menopause, before your rheumatologist increases your medication, ask one question: did anyone check my hormone? Because you are not imagining it. You deserve care that treats the whole picture, not just half of it. The link to the Women's Hormones and Autoimmune Balance program is right here in the description of this video. And if you want to understand the musculoskeletal syndrome of menopause, which is a condition that causes joint pain and morning stiffness and fatigue that can look exactly like a rheumatoid arthritis flare-up and that most doctors never heard about, this is the video that you need to watch now.